So I spoke the other night with Stephanie Green at a forum, so some of the stuff that I discussed then, I know it's a larger audience here, so I'm going to whip through some of the stuff and get on to the more interesting thing. The thing that I'm really interested in, and I'm sure many people are here, is what's this problem and nexus between assisted dying and palliative care. I used to be a GP in a previous life for 22 years, and now for the last 18, 19 years I've been a consultant palliative care physician in Australia. I'm semi-retired, do some locum work in different parts of our fair nation. So I always show this slide because if you're with all due respect to my American colleagues, most people think Australia is somewhere near Switzerland and it has mountains with snow. But that's Austria. So that's Australia. And of course, not to forget Tasmania, Mike, and New Zealand for our New Zealand compatriots. Yeah. We often get thought about it because it's thought to be the arse end of the earth, or that's how it's been described by some Australian politicians. So I live in Victoria. I'm not going to bore you about that, but a regional city of about 100,000 people called Ballarat, and do locums in different parts of the country, so I won't go through all that. Just a little bit of background. I can look down here now, I just realised. The Act started in Victoria on the 19th of June 2019. I was a member of the implementation Taskforce leading up to that introduction, the 18 months between our legislation passing and to being enacted into practice. Since then, about 1,282 people have died from administration of the VAD drugs. 84% in our state, because it's the default position, are self-administration, and we're not going to have that discussion and argument again with Stephanie and the Canadians, and practitioner administration, a much lesser percentage. That's different in other states of Australia. You can actually virtually reverse those figures in some other states like Queensland or Western Australia. And importantly, that 32% of deaths of people who've been approved for VAD don't actually die with their VAD, they actually die of their underlying disorder. And this is about 0.84% of all deaths in Victoria. As I said, I'm really going to focus in on palliative care because I think there's not really been any. There's been some lovely comments about how difficult palliative care has been in this space, but I think we need to focus in on that, and I might stick the boots in unless there are any other palliative care people here. But basically, similar to what's happening in Canada, that we've heard from Stephanie and from Jocelyn, is that 80% of people, and this has been consistent across our 5 years of legislation, 80% of people who've applied for assessment for aid have had palliative care service involved, and the average length of engagement is around the 3 months mark. That's my experience. I'm not going to labour on that, except to say that we have palliative care deaths in our palliative care unit, and this is something that's not common in Australia, although becoming more common, that palliative care units tend to sort of want to shy away from this space, and we'll perhaps explore why that is in a minute. That's probably the more interesting part of the discussion. And really, from my point of view, I've only been involved in one ever intravenous case, a practitioner-administered case at a patient's home, which was all went very well. So most of our patients die at home without a doctor or nurse present. They take their medication. They might have had the medication in the cupboard for 5 months, but they take it and die as a result. We've had no failures of oral administration over 5 years in Australia. So having to have a doctor or a nurse there is superfluous to requirement. Some people request it, as Nick mentioned yesterday. Some people request a doctor or nurse to be present, but you don't have to be. These patients go into a deep coma within 4 to 5 minutes and die at a variable time afterwards, usually within 10 to 15 minutes, although there are some outliers. So just to clarify that again. I think, and once again, this is a little bit different to the experience I've had in Canada, where Vancouver Island, where Steph and Tanya work as sort of the MAID Central in Canada. These patients that I've seen in my regional city are patients from all walks of life, all socio-economic groups, all educational backgrounds, all religious-based backgrounds. In fact, just not long after I left our palliative care unit, we had an application from a Catholic nun to access VAD. She had a terminal illness. So it's not all or nothing rule. And these patients are very determined. Everyone's paranoid about coercion. I understand that. But coercion is not something, it's something I was quoted before by Mr. Kelly, saying that and as my colleague said, coercion's not something we see. We root that out very quickly and assess that. And doctors generally are pretty good at working out coercion. And I've said the other night, people get coerced into having surgery they shouldn't have. They get coerced into having chemotherapy they probably shouldn't have. There's a lot of coercion that way, and coercion against having VAD by people, but we hardly ever see. And you can really pick that coercion, I think, very quickly. And these patients don't even get to first base. They're very, very determined people, though. Depression and cognitive impairment, once again, weeded out early in the process. Patients are not suicidal. Similar to Colin's discussion yesterday, these patients are not mentally ill and are very offended if there's any suggestion that they're mentally ill. Although we obviously make assessment of people's moods and their state to see that it's not affecting their decision-making capacity. All of them, my patients, have accessed good palliative care, although I'm biased because I provided it, most of it. Okay, so why is this problem that we have with palliative care? A lot of my lay friends who are not involved in medicine say, well, why don't palliative care embrace assisted dying? I mean, it's part of, isn't that part of your gear? It's part of your space. And I said, yeah, you'd think so, wouldn't you? Because we're supposed to be the experts at caring for patients, getting on towards the end of their life, to assist them to get as much out they can out of the rest of their lives. Having difficult conversations with people. But of course, and you've probably been reading that, but those who perhaps can't see that, there's a lot of, as we know, and this, I don't want to tell my grandmother how to suck eggs in this country, but basically a strong basis of hospice care, death care within the Catholic Church. 1879, Our Lady's Hospice here in Dublin, and not that long after that in Sydney, Australia. St Joseph's Hospice in London. And 55% is the most recent estimate, 55% of palliative care service, both inpatient and community in Australia, are run by the Catholic Church. Now, as we've mentioned earlier, there's a variable approach to that by some of these Catholic institutions, and I can expand on that later. But by and large, therein lies some of the difficulty. You can hardly get through a whole palliative care lecture without mentioning Dame Cicely Saunders. So I've made the cardinal error, I've mentioned her. But perhaps not to be derogatory about her, her contribution to palliative care in the 60s and establishing St Christopher's Hospice in London, but really because she was making statements like, I've introduced palliative care so that we don't have to have euthanasia. Suffering is only intolerable when nobody cares. I mean, that's arrant nonsense in my view. So Saunderism has filtered its way right through palliative care, and it's still mentioned. I was at our National Palliative Care Conference 2 weeks ago in Adelaide, and once again, almost every talk mentioned Dame Cicely Saunders. There was only one talk about VAD, despite the fact that virtually all of Australia now has laws for VAD. But basically, concepts of autonomy, and ideas about ethical viewpoints have evolved a lot since the 60s. But not in some areas of palliative care, unfortunately. The other problems, the World Health Organization defined palliative care in a fairly, I thought, quite an interesting way. But part of it says, palliative care intends neither to hasten nor postpone death. And in fact, that's rubbish, because there are things sometimes in palliative care when patients are doing well in palliative care. According to one of your papers, Jan, people can do well in palliative care, and sometimes you do forestall and stall their death because you intervene in a positive way to improve their quality of life, and actually may lengthen their life to some extent. So we actually do sometimes intend to postpone death, so this sort of perceived wisdom of neither hastening nor postponing death is really out of date. So what are the values of palliative care? Jocelyn stole some of this, not from me, but because she had nice red writing on hers, and so did Stephanie. But the values of palliative care we all know about: dignity, empowerment, compassion, equity, respect, advocacy, excellence in practice, being good at what we do. Just keep these in mind as we talk. And of course, what's the essence of palliative care, which is a similar thing really, but it's about patient-centred care. Everyone talks about patient-centred care and palliative care. We talk about respect for patients' autonomy. Where would you like to be cared for? Where would you like to die? All the respect for their voluntariness and autonomy. we're interested in competence in practice, of being good at what we do, with good as best we can, pain management, symptom control, all those things. We want to relieve suffering. We want to address medical futility. We already heard from Brendan yesterday about, medicalisation near the end of life. We want to address unnecessary prolongation of life. And we want to be about non-abandonment, which made me choke yesterday when someone, I think it might have been Brendan, said, if you go into someone, and well, it certainly happened in Australia, we say, oh, I'm interested in a voluntary assisted dying, I'd like to know about it, and the doctor shows you out the door. And that's what I call abandonment. And it's happened in palliative care circles in Melbourne, in my town, in my city, or our city, is that patients have been moved out of the palliative care unit at 11 o'clock at night, ridiculous things like that that's happening, and has happened in Canada as well, particularly in BC, but other parts as well. So all these essences of palliative care sound all really nice, but the European Association of Palliative Care just released a new framework on palliative sedation. And once again, they shoot down some of the arguments that we've heard about over the years about, if you have good palliative care, you don't need assisted dying. Well, basically, most of the sensible peak bodies will now say that people, even with the best and most comprehensive palliative care, there'll be still patients who will suffer physical, psychological, existential distress near the end of life, and conventional treatment options will fail them. The term suffering is used to encompass distressing physical and psychological symptoms as well as states of existential suffering. And this is really a recognition by this organisation now, the European, even though they don't come out and support assisted dying, it's a recognition that there's more to suffering than just, vomiting and pain, that there's actually existential suffering. I mean, how you tease out physical from psychological, I don't believe you can. It's all suffering. It's a global phenomenon. And there's lots of different parts of suffering that need to be teased out and addressed. But this is important because they were bringing out a statement on palliative sedation. So what happens in palliative care is that people said, well, we don't need assisted dying, we don't like assisted dying. It's against our ethos because we've got palliative sedation. So if you're suffering irreparably and intolerably, we can just sedate you. So that brings up a whole range, and that's a whole talk in itself. But some interesting stuff's been done by Ben Coburn at University of Glasgow on this, on autonomy and voluntariness. And really, a lot of the stuff is questionable. I mean, is it okay then to say, and how often does the patient get a say in this? They're often, by that stage, raving to the grave, as my friend Michael Ashby would call it. They've either become quite cognitively impaired, have a hyperactive delirium, or in such distress that they're not able to make a voluntary. So the decision's made, I guess, by the doctor's staff in conjunction with the other decision makers. So some patients' autonomy and voluntariness is not taken into consideration when it comes to palliative sedation. And sometimes there's been no discussion about that option prior to the patient becoming lacking capacity to make that decision. The means of relieving suffering is, one they will say, well, we don't intend to kill them. We're going to relieve the suffering, and you guys intend to kill the patient. But basically the motivation, in my view, is the same, and that's to relieve suffering that's intolerable to the patient. And these people who advocate strongly for palliative sedation seem to be okay about bringing about what I call the social death of a patient, but before the physiological death. And not all people want that. I mean, people lay there for days and days and days and days. Not all people want to be socially dead before they become physiologically dead. So the orthodoxy of palliative care would say, we emphasise a different motivation. We relieve suffering on one hand, you people kill them and end their life. Palliative sedation is always morally preferable to voluntary assisted dying. I think that's an interesting debate and not my view. Palliative sedation can meet the same needs as VAD. So VAD is unnecessary, we don't need it. And that they're distinct and diametrically opposed interventions. But from a more pro-VAD viewpoint, we would say that palliative sedation is often commenced without a patient's consent, as opposed to voluntary assisted dying, and always highlight the voluntary. People know I flog that point, but the word voluntary is exceptionally important when it comes to having these discussions with all sorts of naysayers. palliative sedation, in our view, and in the view of many practitioners around the world, is part of a continuum of end-of-life options. Pardon me. Palliative care, assisted dying is one option that people may look at the end of life. Both of them are directed at relieving suffering. VAD preserves a person's autonomy and agency till the end in most cases, although there may be other views on that. And in my view, of course, palliative sedation is an important thing. I use that in palliative care frequently, but they both have you can sustain ethical arguments for both of those positions under different circumstances, as long as you're providing the patient with some choice about that, even hopefully prior to them needing palliative sedation or assisted dying. So what I would say to palliative care people, and I probably should be talking to the converted here, but who decides whether palliative care is incompatible, VAD is incompatible with the values and essence of palliative care? All those things we saw on that list before about the values and essence of palliative care are not inconsistent with assisted dying, in my view. Expanding the repertoire of genuine and legal options for people in their end of life does enhance their autonomy. Autonomy is incredibly important. It's important. I know it's often relational autonomy, that people will not make decisions in a vacuum, but they'll make decisions with the appropriate input from the people they trust and want to. So Ben Colburn says voluntariness is central to the autonomous life, and I believe that the option of voluntary assisted dying does nothing to undermine palliative care's values and essences, as I've said already. Apparently that's 5 minutes. 5 minutes, that's great, because after that the floor opens up and I disappear. There's a hatch, Brendan tells me. Okay, so just interesting to look at some of the position statements around the world. I don't know whether this interests you or not, it fascinates me, so bear with me. The International Association of Hospice and Palliative Care, a worldwide body in 2017, believes that no country should consider legalisation of assisted dying until they ensure universal access to palliative care and appropriate medications, including opioids for pain and dyspnea. Once again, this disconnect between, top-level palliative care, and therefore you don't need VAD. So why? So let's have people suffer for a number of more years while you're getting top palliative care in place. It's a nonsense. You don't need to wait. They can exist. They can coexist. But having said that, the International Association of Palliative Care, Hospice and Palliative Care, put out a survey and said about half of their surveyed members were against any form of assisted dying, and nearly half are in favour. So they've sort of backtracked a little bit. The EAPC put out its white paper on assisted dying and euthanasia. In 2015, we found a broad consensus in the palliative care community in Europe that assisted dying should not be part of palliative care. And they copped some criticism from Luc Delion and Kenneth Chambriere from Belgium about that in the one of the journals, which was lovely. The Association of Palliative Medicine, Great Britain and Ireland, 2020, opposes any change in the law to licence doctors to supply or administer lethal drugs, etc., etc. The Canadian Hospice and Palliative Care Association, 2023, said provision of MAID is a practice separate and distinct from palliative care. This is a common statement that's often made. These are distinct practices. Rubbish. And I'll explain that. It doesn't have to be a distinct practice. Canadian Society of Palliative Care Physicians, 2019, MAID is not part of hospice palliative care. It's not an extension of palliative care, and nor is it one of the tools of the palliative care basket. So, very, very black and white statement. We don't want anything to do with this. The American Association of Hospice and Palliative Medicine take a more neutral position on this, and they acknowledge that moral, conscientious individuals adhere to a broad range of positions on assisted dying. Quickly through. Irish Hospice Foundation indicated also a neutral position in their response to the Oireachtas Committee's report, and that hasn't changed, that palliative care and assisted dying operate completely separately. So once again, be warned, everyone's got to be warned that if you're going to bring in assisted dying, don't expect palliative care to be involved. The Irish Palliative Care Medicine Consultants Association, not surprisingly, said they don't support this at all. And they were deeply disappointed that the majority Joint Oireachtas Committee on Assisted Dying recommends a change in legislation to allow for assisted dying, both euthanasia and assisted suicide in Ireland. So they're deeply disappointed, sadly for them. The Irish Association of Palliative Care against any change in the law to legalise PAS, physician-assisted suicide, which I hate the term. Practice of euthanasia is contrary to the principle of avoiding harm. So this is this concept, that first do no harm. So, I'll leave that with you. And it's the most fundamental principle of governing the doctor-patient relationship. Well, I'm here to tell you, and Stephanie would tell you, and any other doctor here, Nick would tell you, been involved in providing assisted dying to people. It only, in many ways, enhances the doctor-patient relationship, and there's no need to be afraid of that. The All Ireland, I just heard about the All Ireland Institute of Hospice and Palliative Care. Couldn't find anything on their website pro or against. The Hospice UK take a very strong position. It's not our role as a hospice, not our role, Hospice UK, to either support or oppose. Australian New Zealand Society of Palliative Medicine, my peak body, also updated in 2021 against it, although we've just had a questionnaire, and that's probably going to change. And my hallelujah moment was when Palliative Care Australia, our peak body in Australia, have come out with I'll let you read that, I won't go on with it, but basically they are also unfortunately saying it's a practice separate from palliative care, but at least go on to say there's an emerging interface between palliative care and VAD, which is encouraging. So we ought to understand that there is such a thing as palliative futility, that palliative care isn't able to relieve all suffering. Patient choice to either engage or not engage or disengage with palliative care. Well, palliative care people hate that. They hate the notion of palliative futility, and that prolonged dying with palliative care is unacceptable to some suffering patients. And finally, I think this is my last slide. Palliative care is a style and philosophy of care for patients with advanced, incurable, progressive illness, whereas VAD is one type of choice, a choice that some people might or might not make, amongst many other choices like removing themselves from their assisted ventilation and all those sorts of things. And traditional definitions of palliative care, like the World Health Organisation, have not kept up with the progress in palliative medicine, nor changes in the ethical and the social mores of our times. And VAD can be readily integrated into palliative care. Don't let anyone tell you it can't. It is in a lot of places. Canada, it's happening in other parts of Australia and our parts of Australia. Unfortunately, we're a minority. And finally, it just requires the right attitude. It requires good personal ethical reflection, and a real emphasis on patient-centred care, respect for autonomy, and it can be done. So thank you very much for your attention. Thanks, Glenn.